So for session two, we had a really great discussion about some of the interplay between the federal and state laws when it comes to the regulation of AI. And we started talking a little bit about some of the implementation challenge. And so now we will have a session focused more on these implementation challenges, some of the wins and losses, as well as some issues pertaining to impacts on clinical care and the workforce. Also, if you want, since the camera is coming down this way. Yeah. So we have a few speakers joining us both virtually and in person. Coming back again for a second panel is Jesse from King and Spalding. We also have joining us in person Awais, who you may have heard from a little earlier. And then joining us virtually, we have Tonia Burke from Secours Mercy Health, Karim Hanna from Tampa General Hospital, as well as Kaushal Solanki from Eyenuk. Thank you all so much for joining us for this session. I will turn it over to you all. Thanks.
You're good. All right. So this panel is, I think, actually, Lydia's smart how she does these things and scheduling it, because this is a good panel that kind of, I think, is a bookend to what we just discussed, because a lot of it was, what do you do when you've got like an uncertain regulatory climate in the AI space? So a lot of that involves like, decisions about, where you're seeing the benefits weighed against the risks associated with AI. This is more of a pragmatic panel. This panel is more about, hey, so, and there's a lot of coverage on this by the Wall Street Journal and a lot of business publications. Where are companies, where are organizations, where are they actually seeing some ROI on AI? Like, what are some cases that are totally working out, and what are some AI failures, right? That you're just like, I wouldn't not have done that again. Like, we spent a lot of money on this tool, and it didn't really get us anywhere. And that's a lot of what this panel is all about, because I think that I don't work at McKinsey. I am a lawyer through and through, but I do get asked this question, which puts me in an interesting spot about like, hey, where are you actually seeing use cases that actually make sense? Because depending on the organization that you're in, if you are a large organization, you could be the recipient of employee performance metrics tied to using AI for tools and for processes and uses that you totally think are ill-suited for AI. And you got to kind of deal with that. Or you could be at a smaller organization that's a little bit more nimble and they're trying to figure out what makes the most sense, or somewhere in between, probably both. So that's a lot of this panel. With that maybe as an intro, I'll turn it over to some of my friends on video to share any thoughts before we jump in.
No, I think you did a great job.
I think we need to increase volume. Hey, we're having a little trouble hearing you, Dr. Hanna.
Yeah. Can you hear me now? I mean,
It's not. It's a little low.
I wonder if it's on your end, because my mic is
better.
maxed up. Okay, is that better?
Yeah, it's perfect.
All right, great, fantastic. Well, I was just saying you did a great job introducing us. I think this conversation is an important one. As a clinician, I think as clinicians we have certain viewpoints, and I hope that they're useful for you all as you're gleaning from these conversations today.
Tonia, I think you could introduce yourself next.
Oh, sure. Hello, my friends. I am Tonia Burke. I'm the System Director for Virtual Care at Secours Mercy, and super excited to talk about this topic. My perspective is going to be coming from a pretty large health system and some of the things that we've done with AI. And the perspective for me today is going to be from Virtual Safety Companion, or AKA Telecity.
Great, and I'm Kaushal Solanki, founder at a AI digital health company called Eyenuk. So I'll bring perspective from the industry side. As we go and implement our technology, we have developed one of the first fully autonomous AI system for detection of, vision-threatening diabetic retinopathy, and with an FDA clearance and regulatory approvals globally. We actually are being used in 20 plus countries globally, with a large major focus in the US. So I'd be happy to share about implementation challenges that us as a company and our customers encounter.
All right, awesome. So maybe I'll set the table a little bit with like something that's high level that probably won't be helpful, but like maybe we'll have like some nuggets of helpfulness, and maybe people can kind of color in on things. So there have been like a lot of studies that have tried to look at where AI really is moving the needle for organizations and where it's either stymieing development or just slowing things down. And that's really the opposite of what the intent is behind AI as we're defining it right now. And these are studies coming out, and there's whether it's an independent organization or journalistic outlets, they kind of coalesce around these ideas. AI is very, very good at performing functions that involve information that's readily accessible, and it's very, very good at doing tasks that are repeatable, right? So it is. So if something needs to be done quite a bit, and the information is available for it to be able to glean what exactly it's supposed to be doing, it is super good at that. If it's something that is bespoke, it's never been done before, it's only been done once, and the information isn't necessarily available in a large language model because it's sitting in somebody's head, or it's sitting in like a conference room like this one that's not being recorded, it's really ill-suited for that, and it just can't get you very far. And with those broad principles in place, I don't think that anybody that's played with AI, I don't think that should be surprising to anybody, because it has a lot of promise associated with it. But at the same time, the use cases totally have to make sense. Otherwise, you're just kind of banging your head on the wall. I also think that a lot of things come down to the quality of data, and because it largely is, it's kind of like an athlete. Leslie and I were talking about this a little bit. There are certain areas where, if you have really high quality data, and particularly if it's publicly accessible, you can get a pretty good output. But if a lot of the data is noise, or if it's sort of like marketing genre or marketing jargon rather, you're not going to get a lot out of it. And also, if there's no context associated with it, you're going to get an output that's they call it work slop. That was the report that came out recently by an independent organization, where it's laced with jargon. It sounds really, really good, but it completely lacks substance. And that same report that coined the term work slop, it actually said that enterprise organizations, if they're being plagued by work slop, it can cost on a per employee basis $120 per hour per employee, because they're having to deal with work slop, because they'll get a task from like their boss, or like whoever their manager is, to do something that was generated with AI that doesn't make any sense. And then somebody has this reluctance. I can remember being an associate, and I only asked the partner if I absolutely had to, for further instructions. So you spend a lot of time trying to figure out what the F somebody's trying to ask you to do. And the same thing can go up, because now I'm a partner, and I can tell what I'm getting in AI response, because I just think this sounds great, but it doesn't say anything at all. So I have to go back, and there's frustration, right? So there's that tension, but also there's some total areas where, the needle is being moved and people are seeing some things. And, maybe it's a baby step approach that ultimately leads to larger leaps, but maybe with that intro, if somebody wants to jump in from the video and kind of talk about some things that they're seeing where you're really seeing some gains, or maybe even some areas where you're just like, this was a big time miss.
I'm happy to start with a few things that we're doing practically. And so one of the things that everything that we're doing with AI has to have an ROI component to it, as well as a safety or quality component. And so from that perspective, we, from a virtual safety companion perspective, some of the AI that we're actually doing a pilot with right now is we're seeing if we can extend the amount of patients that we can watch safely. And obviously the tie to that ROI is from a Laborlytics, looking to see, how many additional patients that we can monitor. And so, but one thing that I would always encourage everybody is you have to be data obsessed, because quite honestly, one of the things that we've spent a lot of time doing during this pilot is we go through absolutely every AI interaction to validate it and make sure we can agree with it. Because one of the things that we want to be very comfortable with is that the AI is performing the way we expect it, and that we can make sure that when we're talking with our CNOs and our chief medical officers, that, they're going to feel comfortable with the data too.
I can follow up, and just as a short intro, I didn't tell you all where I'm coming from. I'm from Tampa, USF, and Tampa General, and I'm a family physician and also boarded in clinical informatics. And so, as an academic doc, the amount of administrative burden that is on the clinicians is a big place for where AI can play a large role. At our institution, we rolled out AI scribes, which sounds like exactly what exactly what it sounds like. You've been in a meeting where AI is now, transcribing the meeting and taking notes for the meeting. Imagine the same thing when you're seeing your doctor. The doctor is leveraging their phone as a microphone, and the conversation is recorded with the patient's permission. And then the note is then transcribed, alleviating some time in the day and really a lot of headache. But like what was mentioned or alluded to earlier, AI is really good at low-risk tasks and things that need to be repeated often. And, while note writing is not the highest risk piece of the patient care, there's definitely risk. So there definitely needs to still be the, quote, human in the loop, as is referred to often, and those notes need to be reviewed. But we've found at our institution, especially across primary care practices and across the subspecialists as well, that these tools are helping what we call pajama time, and there are several studies on this that were published in JAMA in the New England Journal, and allowing physicians to regain some of their time from focusing so much on the menial task of typing out a note after a visit.
I had a comment to that, if I could. So this is Leslie, and I'm from Privia Health. I think that you touched on a really important aspect of what we're seeing, and something that I think when you're thinking about your business leaders and your organization, one of the things we had to reframe as we put together our AI governance is we shouldn't come at it from find out what AI can do for your department. You really need to first identify the problem. What do we want AI to solve? And the administrative time with the physicians is obviously a big one. And I would say we've seen incredible success with ambient note takers, AI note takers, and we have a multitude of our physicians utilizing those. We've also seen it with value-based care. We have integrated AI that will read the medical record and find those gaps in care. Patient hasn't had an annual wellness visit in the last 2 years. Actually, patient did have a mammogram. The report was buried in this provider's inbox who left 2 weeks ago because it came in via fax and she never added to the medical record, something to that effect. So those type of more administrative burdens we found, but I really would caution that as you start to look at AI, instead of looking at it as what can we use this tool for, really focus on what the use cases are and less focus on just, we're going to use AI, and also you have to get a governance program implemented prior to the usage. I just, as a lawyer, I can't stress how important it is so that your clinicians or, your rev cycle or whomever is going to be using these tools know what the guardrails are, know what to ask the vendor when they're looking, give them parameters and guidelines, and know that, we as a company are going to mandate human in the loop. We will have no autonomous AI, something to that effect, and make sure you have that governance in place from a defensibility standpoint. I think is crucial before you even start thinking about how you would implement in your practice.
And the governance needs to include a variety of skill sets, not just clinicians, but, I would say some finance, some HR. It needs to actually have representation of the entire health system the ecosystem.
Hi. My name is Awais Bajwa. I wanted to introduce when the panel speakers were introducing. I'm one of the panel speakers here today. Didn't get a chance for introducing now. I am coming from a different perspective here in this discussion. Just to introduce, I'm a startup founder. I have an artificial intelligence-based retinal disease diagnostics company. We started originally as a autonomous AI algorithm. We went to FDA. We just we didn't pursue our clinical study. At that time, it was very expensive for us as a startup company. And we believe that we developed one of the very, class A algorithm, but the cost of FDA was too high. So then we just decided to find a secondary way. We just went to market with an assistive artificial intelligence. This is one of the hurdle for any innovative startup company. Like, what is the cost of innovation is in America? This is too high to bring any innovation, of course, as an autonomous. But the good thing is that we learned from the experience that maybe our decision at that time was right. Now, when we talk about wins and loses, or what we won, what was our hard experience, and what we learned the hard way. So in artificial intelligence, I think this is not a yes or no. It is what exactly you're going to implement. You have to use AI as a startup company. We have a team of 8 people. Now we are in 34 states and we are operational. It's not possible without AI. Now, what I go back to the point that you raised, what best practice we are using is we are categorizing AI. What is the external facing for the patient care, how we are delivering care to patient and the customers, and one is internal facing. So external facing is, of course, we are using some of our engines that is using AI, that is not diagnostics, that is using all imaging based AI. And we are using assistive artificial intelligence, meaning that if any one of our readers are diagnosing the AI, so if there is any mismatch, AI will flag that. So that is going pretty well. Our internal AI is that how we are using our internal priorities of the company, of the startup, like where we can exactly use AI and what is the ROI on that. So there is a proper framework we have developed. All the people who want to use AI, we ask them to submit a use case, very small process, and then we go through the metadata of all those use cases, what we can achieve, how quickly we can achieve, and what is the strategic level objective we can achieve. So I think this is a framework that all organizations, of course, are using. We call it as a AI governance framework, and it has multiple factors of how we can quickly generate return on investment on the existing AI methodology. So anyway, I'll just stop here. This is some of the perspective from the startup company. That is, AI is a must have for us for internal use also.
Yeah, thank you. So I just wanted to kind of carry on from what some of the points made today, especially regarding, AI governance and, how to safely implement AI. And, as a company, as a founder, actually, who started this company way back in 2010 when no one was talking of AI, we did look at, what can we do to bring very safe and effective AI to the market. And, we go back to the core principles of using good science and a lot of proper testing. So, Tonia and, others did bring up proper validation. And we also looked at, and another point is that, looking at administrative AI versus clinical AI, and what we work on is this clinical AI with very narrow use case where people are not getting screening for diabetic retinopathy, and how can we enable family physicians and primary care doctors to do it without needing the expertise. So we had to go the autonomous way, but it is a big safety concern. So we went out and validated this on hundreds of thousands of patients. So one of the things I would say, if you were sitting on the other side evaluating this AI, then go back and look at the evidence that is behind this, what kind of clinical evidence that these vendors have published, for example.
If I can touch on this concept of autonomous, and if I'm talking too much, y'all can tell me. I'm okay with being told that's enough. But I'll say something. As an informaticist, these models are trained. These, like the generative AI that you're used to hearing about, ChatGPT, Google's Gemini, etc. They're trained on a whole lot of stuff. But when we're building models that are tailored for clinical decisions, we have to be really careful what data is leveraged, as has been mentioned already. Poor data will yield poor outcomes. But at the same time, we need to keep in mind the physician's role and the relational piece of the interaction with our patients. So as a clinician, I've gotten the opportunity to kind of speak on this several times. I wonder at what point will the AI start to nudge me and tell me, Karim, you're missing this sleep apnea potential diagnosis. You need to make sure you put in the sleep study. Their BMI is X, and they're complaining about X, Y, and Z in the conversation, and you're going to miss this, and this can impact their health. So if we're thinking, Batman and Robin, right now AI I think is my sidekick, but I don't think we're very far away from the stance of Karim being the sidekick to this machine that's in the room, the third party with me and the patient. So we have to have good governance. There has to be, I think someone said it very early and hit the nail on the head. AI isn't a fix-all by any means. There are fails, and I'm happy to speak to some failures too. But we need to address first, what are the problems that need solving? I worry about the clinician relationship, and I don't know if I'm speaking to the right group here, but I have to say it, because it's my day-to-day. I care for people. That's my role. It's my job. I get to serve my patients and love my patients. And if the AI tools are trained poorly on data maybe that isn't applicable to a certain population, or are implemented without governance, then we can miss things, and patients ultimately will suffer. So that's something to speak to, this autonomous piece. We just need to be careful. What is AI? That means a whole lot of things to many people. And how is it being trained and how is it being leveraged?
Something I would like to add to what you just said, because I do think that's super important, is when the AI models are training, I've had folks say, we can start at 80% accuracy. And I'm like, 80%, so having a good understanding of what your minimal, acceptance rate is. Because I was like, I'm not going to put a patient in jeopardy, because 20% variance is too much for that. So people need to go in and have a really good understanding of what that learning requires, how many places it needs to learn from, and how you're going to validate it. because that is such an important piece. And I also believe that AI often learns and reacts differently based upon your infrastructure within your own health system, if that's where it's learning. So there are a lot of things to keep in mind as part of the prep for that.
And I think that touches on something that would probably be a little too much of a tangent, but I just want to throw out there that third-party management and vendor management is a huge component of this. We had something like 90,000 new AI startups within the last year or so. Obsolescence is going to be a problem. We're already seeing companies merge. We're already seeing them being purchased, and we're seeing them, frankly, just go away. And so education on the vendor selection side, understanding those things that Tonia just spoke about, such as, what is their accuracy rates? How do they solve for bias? How do they solve for algorithmic drift? What studies and testing, my business owners don't know that when they're putting out RFPs for products. Does the vendor even understand healthcare? Or are they purely technology focused and realize that this was the best place to implement this technology? And so they're going to come. I think we're going to see, especially if it's an AI tool to be implemented with the EMR. EMRs are the worst place to try and learn about technological integration.
You can definitely feel the difference between a vendor that understands how to have a clinical operational discussion versus a pure technologist. And it is very clear that typically their usability as well.
Sean, I see you have your hand.
Yeah, I wanted to make the point that when we looked to develop an AI accreditation, it was actually our user group that was working on developing the program who said we need something for the developers. And it's just all the points that you touched upon is that there are developers who don't know what HIPAA is, who are coming with AI tools, and you're like, oh, good news, you don't need to apply for our accreditation, because if you don't know what HIPAA is, you shouldn't even be doing this. But this is that Wild West sort of time right now where you've got people who their sponsors are saying there's money to be made in healthcare, so they're taking tools not designed for healthcare and trying to throw them in because that's where they want to make money. And I've said before, you can use an iPhone to drive a nail, but it's a great tool, but just not for that. And so we got to stop thinking that technology is going to fix everything if we just try hard enough, and that people who don't trust it are Luddites who are screaming at the sun or something like that.
Yeah, and I think this goes back to the idea that was brought up earlier about cross-functionality when you're implementing your AI governance. It does have to include a vendor management process, and that needs to be your business owners and your department heads and HR, and you're going to make great friends with your legal department, because we're going to be the ones coming in with all the contract clauses about how are you using our data and how are you protecting this and how are you training your model and those kinds of questions. And it is one of the most cross-departmental, cross-collaborative efforts that I've engaged in my organization in the last, really in the industry that I've been a part of for 15 years. So, everyone's on a similar learning curve right now. But I think that creates a lot of opportunity for cross-departmental learning because this is touching every department.
One of the areas that probably we can talk about that, and that's going back to the talk what Hanna mentioned, transparency and openness. Like AI inherently is a black box. Once what's saying, I'm talking about autonomous, so it's yes, no. But why it's yes, why it's no, this is one of the challenges in the industry that as of now, we don't have that openness and transparency. Because if we have more transparency, there will be more trust from regulatory bodies, from physician communities. Because, for example, primary care don't know about eye diseases. We tell them, yes, it is diabetic retinopathy positive or diabetic retinopathy negative, versus we just have some explainability. Now, the challenge is that as more explainability we introduce, FDA is going to ask about more heavy clinical trials. That's going to bankrupt the startup like us. So I think there should be a mix of what we are noticing and seeing like as a win is, again, talking about human in the loop. We spoke a lot, how to have a good balance of algorithmic prediction and human interpretation together. I think this is the pathway to the success of eventual autonomous that can help. And if we see like why we use AI, I mean, why we are using in the clinical practices, if we see the target or why what we want to achieve. So, and we define our target and then we go back. Like main thing is that, okay, physicians are going to spend more time with the patients. Yes, if there is a burden, less burden on the physician, there's better care for the patients. And if we use some explainability and we talk about explainability, transparency, and this algorithmic bias to reduce, of course, that is a part of the training data sets. And also I would go back to what Sean mentioned, although it's not a very appreciated thing that AI should be trained or AI should be questioned regularly, like we ask physicians, but there should be some discussion on how we define the, criteria for AI to be sustainable, because FDA has one approval and then the algorithm is locked. So once it's logged, it's basically over time, we call it as an data drift, concept drift. So it degrades the algorithm in the long run. So we need to think that also in the clinical practice.
When you're thinking of,
Oh, I was just going to say, if we wanted to shift a little bit from the doom and gloom, that so in terms of successful implementation of AI and where we've seen it, I think one big success that we've already talked about a little bit is the ambient note taking and the scribing. I think that's a big burden. I think we're currently seeing a war among the payers and the revenue cycle departments of practitioners in things such as prior authorizations and getting claims paid and using AI to improve documentation, and then the payers fighting back against that because, hey, you used AI. And so I think there's a war going on there. And I think that despite the opportunity, the healthcare revenue cycle is so incredibly complex that I'm not sure AI is quite ready for a full revenue cycle takeover, but I think there are individual tasks within revenue cycle that are probably doable. But also, I think there's huge opportunity in value-based care, as I mentioned before. And that's where we've seen success with a model that is integrated into the EMR. So it is not relying on any external data necessarily, but what it is doing is essentially reading the medical record, which a physician can certainly do, and it would take a significant amount of time for a physician to dig through a record to find out whether the patient had met those measures. But I think that's again, this idea of starting small and starting in places that make sense, as opposed to trying to solve healthcare, which is, yeah.
This is Michelle. So this success story also, I may have shared this story in the summer, but the state of New Hampshire was approached by Blue Cross Blue Shield, and this is public record, so you can Google it, because they paid $62 million more in claims than they anticipated to pay in the last calendar year. So I guess that would have been in 2024. And that was due to Dartmouth Hitchcock utilizing the AI coding and documentation tools that are available to them in Epic. And they improved their claim processing and then clean claim processing back to Blue Cross Blue Shield. So I don't feel bad for the insurance company here, because maybe they should have been paying those claims all along. And we just did a good job of, processing claims. But there is a reality there of utilizing this AI tools and improving, and then ultimately bankrupting the payers that are. So that was what the state was grappling with. What do we do, with $62 million? Because that's Blue Cross saying we're not solvent in the state if we have to continue like this. So how do they solve that problem? So success and failure somewhere in there. And I'll just touch on the EHR comment that was made earlier, I'm hearing more and more that the health systems are relying more and more on the EHRs and less on third parties because the technology is getting integrated into the EHRs. And they're thinking, if I'm going to use a third party, maybe that's only going to be for like 12 months, 18 months. I'd rather just use maybe a crappy version of it in the EHR and they'll improve it in 6 to 12 months. And so then I'll be okay. And then they have one neck to choke under the AI umbrella.
The EHRs are also really hard to penetrate. I'm sorry, I cut you off. The EHRs are really hard to get into, and they intentionally, or for whatever it's worth, have lots of gates to just get in on their side of anything. So, yeah.
One of the things I was going to add that we're in testing mode right now, and it's working pretty well, and it would speed up care, is in the telemetry space. So, but within the telemetry space outside of what we normally would use AI, for example, Philips, whomever would have their own AI. It's like $14 million for us to upgrade. So we've layered an AI on top of that to basically screen share that data centrally, because we're trying to centralize the telemetry. That would be phase one. Phase two is using the AI technology then to send those alerts directly to that frontline team member. Hey, Penny Kite in room 8 is an AFib immediately, and taking that human telemetry tech as minimally out of the picture as possible, because just watching it in test format right now, they're missing several with all the screens that they're watching. And right now, how it is decentralized with the rural hospitals, it's very inefficient. You got one watching 4 here and one. Now, that scares my clinical team to death, because, they think that a human is watching this screen the entire time, when in reality, they're not watching that screen an entire time.
Yeah,
and there's a.
Go ahead, Karim.
Oh, no, I was just going to highlight a comment from Dr. Griffin. I call that the current claims arm race.
Mm-hmm.
Yeah, I like the arm race. That's a good, I've been calling it a war, but yeah.
Go ahead, Kaushal.
Yeah, I was just going to say that, speaking of successes where, we rightly highlighted, ambient listening, which is really saving admin time. So there are a lot of admin related things like revenue cycle management. And I think we should certainly add to this list some of the clinical AI, which work in a very different way. These are narrow domains. These are not large language models. These are very, very specific data trained deep learning models, machine learning models that are designed to look at very specific problems. And in our case, it was, let's say, detection of diabetic retinopathy and allowing patients to be screened in primary care versus, having them sent to secondary care or sent to specialty like ophthalmology. And we are certainly seeing a lot of adoption. Again, looking at something like this, which is autonomous, but in a very, very narrow domain where there is a lot of evidence, published evidence, that this works at, 96, 97% sensitivity. It is even better in terms of sensitivity than ophthalmologists or retina specialists doing standard of care. So my point is that we do need to separate these technologies that have this evidence, that have these clearances from FDA, from global regulatory bodies, and they go through validations within these health systems as well. From the more recent, like the whole panel talked about, sponsors throwing money at large language models and just trying to see what comes out of it, right? And they may not even know what HIPAA is, like Sean said. So, there are certainly technologies out there that have been very properly done with, publications on hundreds of thousands of patient visits versus, and that should go into the evaluation that health systems do, which again is something Iraq and Sean have worked on with accreditation for developers and for adopters, users.
I just want to make take a step back. I think what's happening is we're really hitting the quadruple aim. It's kind of cool to see the examples that have come up. We've talked about population health, we've talked about reducing costs or improving kind of the revenue cycle, and we've talked about clinician well-being. We haven't hit on the patient experience. So I'm curious if anyone has successes from the patient experience side of things. Like, of course, all of these efforts should be to improve outcomes or improve quality of care. But I'm curious specifically to how their walk through their clinical experience, if anyone has a take on that from an AI perspective.
I can just speak that we have been very intentional about avoiding any AI that will be interacting directly with patients. We are right now just talking about the idea of using AI for patient identity verification when they call into our customer service. So it would save the customer service operator from having to go into the EMR and validate 4 identifiers and stuff like that. And instead, the AI can help validate it. That's the closest I'm comfortable at this point with using a patient interaction. There's lots of talks about AI agentic chatbots and other things that sound really fancy and shiny, but I personally just don't see evidence that there is a lot of public enthusiasm with talking to an AI agent from a patient perspective. I see patients want real people. You see it every time when you're calling in on the call tree, when you're customer service perspective. And so until we can, I think, shift a little bit more from the patient perspective, and it could be because we have a high Medicare population, maybe just a little bit, there's a lot of fear and avoidance and concern over the idea that I'm talking to a robot, to a certain degree, that I personally have been very cautious about even entering into a patient interaction space with regards to AI.
So a couple of things. I think it's the age of the population because we're in the same boat, and we've aligned our data that most of the Medicare type patients, the baby boomers and so forth, really would rather talk to a human. The Gen, what is that, Zers? I get it all mixed up, but those are the ones that would be more on the AI side. And our transitional care management data is showing that because we use texting on one side and then phone calls on the other. The one thing, we use a very low end, what I would call AI. It's not agentic AI. It doesn't get smarter as it talks to the patient, but we've used it for a few years and it's successful. It's the asynchronous side where you've got that bot doing the work in the back, but we built it. And before it gives the diagnosis to that patient, a clinician has to review it and accept it. So it's still very simple. That's one of my fastest growing services that we have, but we've very much contained it not to get more intelligent as it goes right now because of what you were talking about.
I just want to share a quick experience. Recently, we had, actually, I put a post on my LinkedIn also just to introduce that pilot of wellness eye exams. We did with Blue Cross Blue Shield a month ago. And we were having a wellness on-site exams, and we got a good feedback from the patients like, okay, this is very quick. This is just 2 minutes exams. But first question what they asked was, is AI doing your diagnostics? I said no. So every patient, because we have a poster as a startup company, we have to do the marketing. We were saying assistive AI exams. But of course, first question from the patient was, is it AI? I don't trust AI. So that's what the thing is. And we did a quick, so our startup is under Georgia Tech. so ATDC. So we asked some of our interns to do a survey analysis. So 7 out of 10 patients from all these populations that we conducted some of the wellness eye exams, so they said we don't want to have AI-based diagnostics.
Maybe just a comment, and then I want to ask a question. But I do think norms are shifting, and what we're seeing right now, I think, will change, and stats are bearing it out. Like if you look at what a lot of the large language model companies are willing to release to the public, it's interesting for me. I'll turn 46 in 2 months, so like this is, so I definitely like, I was in college before cell phones were like a thing, right? So like, but in the summer this year, they reported that 4% of adults were using AI for companionship purposes, however you want to define it. They released another company with a very comparable model, released a similar sort of survey, and it jumped up to 30%. So that's pretty huge, right? So, there's just something to kind of think about, that patient proclivities will probably change, as this becomes more of a norm. But what I want to ask is that, and because I see it a little bit in my setting, but it's not so much that the tool's not useful and that it won't work. It's just that people aren't trained properly on it, and then they get frustrated. So I was wondering if anybody had any comments on the importance of training, because that's something that I actually hit on quite a bit when it comes to AI governance and AI compliance, is that you actually need to train your employees on how to use these things. Otherwise, you've wasted a lot of money, and you're also getting zero gain on it. If anything, you're taking steps back.
Yeah, we've incorporated a training component into our governance model, but training people how to just write prompts, even when you're talking about like a Gemini or ChatGPT, can make a huge difference in the quality of the outcome that you receive. So we haven't fully developed our training program yet, but we are writing it into our policy and charter that there will be training required depending on we're using a risk-based model. So we're going to stratify our tools, low, medium, high risk. And so depending on the risk level of the tool will require the level of training required.
Hanna. Karim?
Dr. Griffin was before me, if you want to go ahead, sir.
I think they're tired of me at this point, Karim, just to be honest with you. A couple things. I'm getting a bunch of feedback. I think the use of AI is generational at this point. It's significant. When I was practicing, I had patients who, if I told them to go home and chew their leg off, they would have done it because I was the doctor. And I had other patients who doubted every word I said until they Yahoo'd it, just sort of depending upon what was going on. One of the big uses I have seen actually is health literacy. So people are getting diagnoses, and maybe in the moment they're not understanding it, or they have questions about it, and they feel comfortable going to a chat bot or some other source to get better information, just like they used to Google it. But now they're actually talking about treatments and care plans and those sort of things, and using AI tools for doing that. And I'm seeing that in a younger generation, because my kids don't want to talk to anybody on the phone. They'd much rather go to a chat bot. And then the other thing I want to say is on pajama time, one of the big questions is going to be is if we have these tools and they're allowing doctors to document more effectively, is that resulting in more visits being added to their schedule since they don't have to spend the time on documentation? And are we therefore going to add to burnout as opposed to lessening burnout? So those are just some of the thoughts I had.
I hope we're not adding to doctors' schedules just because they're more efficient. I hope not, but you never know. I'm not making that decision. So the piece about leveraging or including some sort of training, we've included it for our medical students, so they're teed up really as a practitioner or as a clinician how to leverage these tools, so they have a little bit more insight, and as well as our faculty, so they're aware of how patients can use it. And we've actually published on this, on patient-centered kind of explanations for pathologies that are common, so that patients are leveraging it, they are using it so that they can learn more. I think that's a huge perk. It was Dr. Google, and now it's Dr. Gemini, what have you. But these tools are becoming more common, more mainstream. I worry kind of the fear is the skill attrition. So if you continue to lean into these tools as a clinician or as a patient, naturally things will be lost. Things will be lost in the dance. I don't know how to express it. There's a really nice study, and if you can tolerate me for another 10 seconds. There's a really nice study of radiologists who read mammograms, and they do a pre-test on these radiologists reading mammograms. They do a great job. They add an AI tool for 6 months. They do even a better job, and then they remove the AI tool. So the radiologists post 6 months of this AI leveraging this extra thing are worse off than before. So what are we doing to our clinicians? How are they using it so that they're not becoming over-reliant, so they're not losing their skill set? It starts from training our medical students. Are we training them to leverage it appropriately? Are we advocating for our patients to use it in the right way with the right tools? I don't know. There's a lot of unanswered questions that I have.
I think you can extrapolate that too into the workforce in general. A lot of talk, and even among my leaders, as much as I chastise them, have talked about, well, how are we going to, can we reduce FTEs? Can we reduce FTEs? How many FTEs will this reduce? And the truth is, you can't really replace. You might have to retool or retrain your FTEs because they're going to have to learn how to manage an AI system versus doing the manual work themselves. But you're always going to have to, there's this skill set that the AI learned off of something. And if we start to replace that something, if we're no longer having people who are trained in the various, disciplines that AI is supposedly replacing, we're going to lose the source of the information that the AI needs to learn off of. And so I really, really hate discussions around AI replacing FTEs in workforce. The discussions really should be about how do we make our workforce more efficient so we can retrain our employees to manage the AI to have better outcomes.
I just want to add one comment here. So I love this point of view, and also I 100% agree. Like, basically the competitive advantage in the market is that how efficiently using AI. I mean, you cannot replace AI, but replace people with AI, but how efficiently using AI. And also going back to one point on awareness, like a lot of people think that, okay, AI is a magic. So basically all these LLMs are generic information. If you want to talk about any specific information about your organization, about your operating model, about your own business, LLM is not going to answer that. LLM is not going to answer your team members' performance. So basically, this is again going back to the awareness of your team members, of your organization, of your employees. And second thing is, there are some best practices. Like in a startup company, what we're doing is we have a library of prompts. Anyone want to write a prompt? We have a already reusable library. You go and you're talking about the customer marketing, go and download that prompt. So this is I think few best practices we can adopt and educate the people. Okay, if you want to do any specialized knowledge, build your own SLM, small language model within your organization instead of relying on LLMs.
So, sorry, Joe, go ahead.
This is purely anecdotal, but with respect to the importance of training and the risk of errors, I think this may have been at Cornell. I read about it a year or more ago, and so my recollection of it is a little hazy. Problem was that the AI system they were employing to aid in the interpretation of chest x-rays was generally biased in the direction of assuming that if the film were a portable film, as opposed to one taken down in the radiology department, the patient was sicker than was the case for a comparable film or even an identical film when the location at which the study was done was different. And it turned out that the explanation was that a lot of the films used to train the AI to interpret x-rays had been based upon portable studies done in the intensive care unit because those patients were too sick to go down to radiology. And so two images that were otherwise substantially identical, the AI would assume and would report that if there was some indication of a supportable film, then this study must indicate a more severe problem than the other study done in the radiology department. I just thought it was a kind of amusing and frankly sort of fascinating example of what can go wrong.
We have 3 minutes.
Okay, so I'm going to make maybe a provocative statement about the future of AI. Okay, so I get some cheers for that. Are we starting to care that we can't go to the Encyclopedia Britannica, or that we all can't remember how to do the Dewey Decimal System? I mean, that stuff is there, but we don't do that anymore. And this is the new process, right? So yes, we need to train on AI, 100% need to happen. The lost skills, there's my provocative statement. I think my personal story is my son is going to medical school, and the data is showing that 30% of these kids in college are using AI. I thought it was higher because everyone that I talked to of his friends are using it, and they're not going to the stacks and looking at, papers or books anymore.
I think it depends on what the skill is that we're losing, because I think in law school was one of the last class that learned how to shepherdize with books. After me, I don't think anybody even knows what that is anymore. And is it a necessary skill to have? And I think that's the question: is are we losing necessary skills or important skills or not?
Echo. Okay, yeah, there we go. And to kind of react to that too, if there's a silver lining, I think it's for a lot of white collar professionals. This is an opportunity to level up too, because for a long period of time, lawyers, doctors, mechanics, they had an information superiority where you would take your car in and you had no idea what was wrong with it. And they could come out and they could say all kinds of stuff, and you more or less just have to believe them. Same thing if a non-lawyer came to me for advice, and I represent a lot of startups, and startups, it shouldn't be a surprise, do not have the money to be able to retain a general counsel. And even like generalists, they just don't have enough time to dive into it. Doctors the same way. I mean, now this technology has given a very democratizing effect such that people, if they want to, they can ask appropriate questions so that they can have more informed conversations. I can tell you that I don't know what happened over the course of this summer until now, but conversations I'm having with my clients are at a much higher level now. And I enjoy that. That makes my life easier, but I think that that's something we all should expect in a lot of ways.
One thing just to, Jesse, what you raised before was eventually with the trust, autonomy, like autonomous decision, or like we have thermometer, right? Temperature. So it's a temperature gauge and we all agree on that, right? So eventually there is a pathway to that will be maybe, I don't know, 5 years, 3 years, 4 years. There will be a pathway. There will be a target when AI will be more trustworthy. What is the pathway to that? How we have this trust as of now? That's the question. I think how we can make it more trustworthy, how we can make it more explainable, more transparent, and people need some more awareness and training on AI. I mean, in all organizations, like they need to understand the technology, right? So that is, I think, the better pathway. And also on the regulatory side, we have to see what is the cost concern on going towards AI.
Well, while we've been sitting here, Time Magazine named the architects of AI the person of the year for 2025. So I'm proud of them for not actually calling AI the person of the year, because then we really have moved the Overton window. But I think of Time Magazine as sort of a general public publication. And so I think it's going to be interesting to see when we sit here a year from now how, to Jesse's excellent point earlier, the Overton window is going to shift, and how fast is it going to shift, and where are we going to be? Because this is moving awfully fast.
And with that, I think we're at 1 o'clock. So we'll take about an hour for lunch. Lunch is in the same back room that we had breakfast in, and we'll reconvene at 2 o'clock.